I'm Hugh Taylor, the Harold Mitchell Professor of Indigenous Eye Health at the University of Melbourne in the Melbourne School of Population and Global Health. And that's my day job. And my night job, I'm the President of the International Council of Ophthalmology that represents 165 member ophthalmology societies around the world. Well, much of the work that I'm doing now is really around the provision of eye care and health services, looking at the patient journey like a leaky pipe, or the pathway of care, that there are lots of steps along the pathway of care where people can fall out of the system. And so they might notice they have a problem, they go to see somebody in primary care, they may get referred to an optometrist or an ophthalmologist, and then there's steps that need to go through to actually make sure they get all the treatment. And so a lot of our work in Australia has been focusing on trying to improve the pathway of care, particularly for the Australian Aboriginal people. And part of that a lot of that has focused particularly on diabetes and macular edema and problems with diabetic retinopathy. Because people with diabetes not only need to have their annual retinal exam for retinopathy, but they also may need cataract surgery or just a pair of glasses. So to provide proper eye care to people with diabetes, you need to have not only the referral mechanisms for the treatment of macular edema or proliferative retinopathy, but also the cataract surgery and glasses for refractive error correction process. As far as AMD, I think work we've done over the years has shown a small effect of UV light and visible light and macular degeneration. But by far the biggest risk factor is smoking. And so in Australia we were one of the first, well the first country to really start the awareness of the risk of macular disease and cigarette smoking. And so now on the packages of cigarettes, which are all plain label cigarettes, the most prominent of the health warnings is actually about macular degeneration, which is actually a big win in terms of that health promotion and public awareness of macular degeneration on the one hand and the risk of cigarette smoking on the other. Well, it's hard to choose your parents and I mean a good balanced diet, but that's really the only thing other than cigarette smoking that one can really do preventively. And then of course you need to have the regular eye examination, particularly if you have a family history. And as in glaucoma, a family history of AMD is actually a very high risk factor. And so I think we need to make sure that every patient with AMD is warned to inform their first degree relatives, their brothers and sisters and their sons and daughters to say, hey, I've got AMD and you're at risk too. So when you go for an eye exam, make sure they check you out and are aware that you have a brother or sister who has AMD. And I think that's a really important preventative message that we're not actually getting out well enough. Marginally. We did a big study, the Chesapeake Bay Waterman study 30 years ago, and found that there was some contribution of visible light, but it was not strong. It's not anywhere nearly as strong as cigarette smoking. And so that one should protect one's eyes from UV light to reduce the risk of developing cataract. And if you're protecting your eyes to reduce the risk of cataract, you're also getting, if there's any secondary prevention for macular degeneration. But so it makes good sense when you're out in the sun to wear a hat and close-fitting sunglasses. But that's really to protect from cataract, not from AMD. I see that what we have the big unmet need of not providing the services and the treatment that we know how to provide. So we see in Australia that still the largest cause of blindness is macular degeneration. Why are people still going blind from macular degeneration? What can we do to make sure that they're not smoking? They're protecting their eyes against cataract as well as AMD maybe, but also that they're getting prompt and efficient treatment. And so I think the real advances we can make today, while we're waiting for the science to develop, CRISPR to develop, long-term anti-VEGF implants, all those other things that are happening, we really should do what we currently know and do it properly.